Excellent. All right, welcome everybody. This is the National Care Coordination Academy. It's nice to see everyone. I hope you are all having a great summer. We have another awesome day planned ahead for you guys today. So you will see our agenda shortly. We'll go through what we have planned. So just our usual welcome and housekeeping, some reminders. This meeting is being recorded. Your team breakout sessions will not be recorded. Please don't use speakerphone if possible. And right now I have everyone muted upon entry, so you will be welcome to speak when we get to our team report out section. And of course, if there's any questions or comments, you'll just have to unmute yourself and then you're welcome to speak. There will be time dedicated for questions, and we ask that you put all questions and comments into the chat, please, and we will be moderating the chat. It's important that we have you rename yourself, including your state abbreviation ahead of your name. That way we're able to easily identify what state you're from, and that will be helpful when we go to the team breakouts. If you need help with rewriting your name, you can go over and find your name under the participant list, find yourself, select rename, and then you can rename yourself, showing them this example over here. As a reminder, we are offering continuing education credits for any of the following professions: RNs, NPs, MDs, PAs, and social work. To be able to obtain your certificate, you must do all of these steps. I'll have you first put your information on the attendance Google Doc. That will be shared in the chat momentarily by Erica Norcus, and then I will also email it to you later this afternoon. We'll ask that you complete the evaluation at the end of today's session. That link will be shared at the end, and then it will also be emailed to you if you miss it. Once both of those have been done, your information will be sent to the Boston Children's CME department for processing. They will then email you within 2 to 3 weeks. I apologize, it takes some time with all the virtual conferences going on, but I promise you will receive an email in 2 to 3 weeks with next steps for how to obtain your certificate. If at any time you have questions or concerns, please reach out to me. Also, I think I mentioned this last time too, but we have a new option now where participants that might not be able to join live today, for up to 6 weeks after the live event, you can watch the recorded lecture on open pediatrics and still request credit. You'd follow the same process. I'm going to kick things over to Rich to go over today's agenda and do some words of welcome.
Thank you, everyone. We are really excited to continue the momentum of the National Care Coordination Academy. I want to express my gratitude once again to our core team, to Heather Pamela, to Erica Norcus, and to all of the key faculty as well. My colleague, Meg Camo, is not able to join us today, and so I'm going to also share her welcome to each of you. We hope that the journey continues to be meaningful for each of you as a team, and keep in mind that success is what's making a difference measurably and sustainably for families. I have some good news to share at the outset here. The Care Coordination Academy has received some additional funding to be able to continue through May 30th of 2022. Details are being worked out now related to how current teams, those of you listening in, and prospective ones, and yes, there are additional teams that want to join from across the country, and how this will how each of these teams will most optimally benefit from the Care Coordination Academy experience. We are really grateful to our HRSA and Maternal Child Health Bureau colleagues for their support and commitment for us to extend this opportunity to continue implementing sustainable, measurable care coordination and care integration for children with medical complexity and children and youth with special health care needs. So you'll see the agenda on the screen before you. We're going to continue with the theme of our Mother's Day card. Dr. Schiff will be taking over. We have two very special guests that I'm going to ask Dr. Schiff to introduce, but you should experience this sort of thread. Last time we had Foster Gueston, where you were getting your Mother's Day card put together in a conversation with somebody from a Medicaid agency. Today, we're thinking about how will you contextualize that tool that for education and advocacy with a policymaker. Then we'll take a break. Then we will do some team breakout groups, the logistics for which I'm not smart enough to know, but I'm sure that Heather and Erica have figured that out. Then we're going to do some team report outs. We really enjoyed the last session where the teams came back in and had time to process and share. So we're going to do everything we can to maintain fidelity to that approach. And then we'll do some closing remarks at 3 p.m. Eastern time. So I think I'll hand it back to you now, Heather.
Yes, thank you so much. Okay, so I'm going to go over today's learning objectives. So after this session, we hope that participants will have an understanding of the key aspects of reaching out to state legislators to impact policy. We hope that you'll be able to articulate the link of the care coordination work and the funding mechanisms needed to make this work sustainable, and also recognize mechanisms to concisely present data on care coordination programming to policymakers. If everyone can please just mute their microphones, thank you. I wanted to put this back up. I want to have this be a theme that you'll see through all of our sessions, but this is, as we refer to as the three-legged stool of sustainability, just to keep this in mind as we're going forward. So what sustainability means is having elements of the care model, measurement, and funding, and all of three of those together will help us get to sustainability. So now I'm going to hand things off to Jeff Schiff. He can introduce our guest speakers today.
Hi, everybody. Quick test. Can you hear me, Heather?
Yes, perfect.
Perfect. Hi, everybody. Welcome to July in 2021. I just said to somebody a couple of days ago that I can't believe we're halfway through 2021. As I get older, I feel like the years, it gets harder to reconcile the numbers. But I will just say really at the onset that I hope I don't cut in and out, but my connection, my internet is unstable and I'm connected. So connected and unstable seems to be my theme with Dr. Antonelli. But anyhow, I'm looking forward to today's session a lot. I've wanted to have Senator Hoffman and Kevin Parker on for a while, although because they have been in my home turf great advocates for improving the healthcare system. And I have known Senator Hoffman since he was a child, not really, but since at least he was before he was a senator, he was on the Anoka County School Board. He has served as a reviewer for HRSA Title V state grants for a long time, is involved in Part C technical assistance, and is on in Minnesota on the health committees at the Minnesota Senate. So he's really involved. And I think the other thing I'll just say about John as I introduce him is that he's a get things done guy, and he's not a, he believes that legislation is an important part of the process and works hard towards it. Kevin's been his legislative assistant for a long time, and we really wanted to have both of them in the room here today because we really think that you need to know that how the wheels turn over at the Senate office building, and John does some of the work, but Kevin does most of it. Or some version of that, but I think it's really important. And we are going to talk about that a little bit. I wanted to frame this in terms of the discussion we had last at the end of May, which was with Foster Gueston, who was the Medicaid medical director in New York, and really talk about the fact that that these are not in a specific order, but Foster was a policymaker at the level of Medicaid and dealt with some of those issues. And John and Kevin really work at the legislative level. If you can go on to the next slide, Heather. Just a couple things to theme this up before we get into our conversation. We have taken Perseverance the rover as our mascot in a way, and I just have to say that on Perseverance is that little helicopter whose name is Ingenuity. It had flight 9 on the 5th of July, and like a toddler, it flew further away from its parent than it did before, and it returned successfully, exploring new territory. So I thought that that theme was appropriate today. Plus, perseverance and ingenuity are really two of the themes of our Care Coordination Academy. I'm going to go on to the next slide. Remember, we started this right after Mother's Day, and we used the metaphor of a Mother's Day card because we really wanted to have people at the end of a few of these sessions have a product they could use to identify and talk about how they're communicating with policymakers or people they need to reach out to. And the Mother's Day card had some key ingredients like like thanking folks, saying what your mom does for you. The distinction I think we're making in some ways, the biggest distinction in the metaphor is that we have to figure out who we're going to communicate with. So I put up this slide from the P.D. Eastman book, Are You My Mother? So next slide, and then we'll stop and have our discussion. So I think that I already talked about this and what the metaphor was. So I'm going to go on, ask you to go on to the next slide. And then we're going to just put this slide up here, but I really want to now turn to our conversation with Kevin and John and really talk about how we inform and move legislation forward. So, gentlemen, if I can just start with some questions and start our discussion. And I'm going to ask first about a little bit about the who over there. So John and Kevin, I don't know which order you want to go into, but I want to ask you guys, we talked about this when we were planning this. What gets you in the door at the senator's office for a meeting? What doesn't get you in the door, and how can these teams from all over the country learn how to talk to senators in the healthcare committee?
So Jeff, I'm going to actually, first of all, thank you for having me here. Today marks the 31st anniversary of the ADA, and it's so important that we're here having this conversation. And I'm going to give you an example of, and I'm going to let Kevin kind of talk about how folks within our industry, there are 201 elected officials in the state of Minnesota representing almost 6 million people, right? Our ratio of citizen to legislator is probably better than any other state, right? I look at our wonderful state of California, and one state senator represents like 937,000 people, right? In Minnesota, one state senator represents 85 to 87,000 people, and that goes up. But I'll give you an example. A legislative assistant in some cases becomes that person, that first point of contact, that person who's going to know the issues better than the legislator in most cases. In our case, it's a learning activity that exists forever. And speaking of the ADA, Senator Jim Abler and I did a whole hearing on reasonable accommodations and accessibility and people with disabilities and state government and Connect 700, yada, 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 all these things that are important to us. Why are people with disabilities the highest unemployed? Why are these things, right? And it caught the attention of a gentleman named Bobby Silverstein. And when I got done with the hearing, I come upstairs into my office, and here is my legislative assistant, Kevin Parker, saying, yeah, Bobby Silverstein called, was watching the hearing and wants to connect. I froze in the hallway, you guys, because I don't know if you know who Bobby Silverstein is, but he was health, education, labor, pension lawyer under Harkin and everybody else. And he wrote the ADA. That's not the most important bill he wrote. The most important was Public Law 99-457, which is the Early Intervention Services Act bill. At least that's in my opinion. But I froze in the hallway, and I looked at Kevin, and I said, the Bobby Silverstein. And then he just kind of looked up at me and he said, yeah, guy named Bobby Silverstein. So we looked it up. But the first point of contact that you guys have is going to be that legislative assistant. So it's going to be important that you create a relationship with that individual from that moment on. And with that, Kevin, you want to kind of talk about how you see the interaction between the public, the greater public, and our office.
Yeah, first, thank you for having me here. So I'm Kevin Parker, Senator Hoffman's legislative assistant. And the simplest way to put it is you are the immediate contact. When you call the office, when you use the numbers, when you use the emails that are on there, you're reaching the legislative assistant. I am the person who's going to, and there's particularly in many different legislatures, including Minnesota, the legislative assistant has access to the emails. So when you're directing an email towards the legislative official, they're probably being viewed by their legislative assistant or some other staffer who's helping them, whether it's a response to a constituent or setting up a meeting. So no matter what you do or who you're trying to contact, you're going to go through that staff, which is why it's absolutely important that you're generally respectful, understand the timelines that people are under. I've had people occasionally try to shoot snide comments behind my back to the senator, not understanding that I'm going to see that. And I've probably already discussed with him what was going on and why this situation developed the way it did so that we could laugh about it behind closed doors. And then subsequently, how we interacted with them changed because they tried to pull something that was not possible. The legislative assistant and the staff are very closely tied to their legislators. So it's always good to be respectful, make it very clear what you're asking for and give options, because the less I have to chase someone down or be like, well, what works for you? If you come to me and say, hey, these times and days are available, we want to talk about X. I love it when people are clear with what they want to talk about, because I have to let John know as best I can what's coming next on the agenda. And if I just get a, hey, we want to meet with the senator at 10:30 tomorrow, you've just caused, that's going to be an email chain going back 5 to 10 times to try to correct the time because we might be busy, find an appropriate time and get what the topic is and how we arrange this. The easier you can make it on staff, the more endeared they're going to be to you. Some of my favorite people to work with are ex-staffers because they know all of these things. And so they're going to go like, hey, we understand this is last minute, or hey, we know you're busy. 2 weeks from now, we're looking at a time. We're going to try to get this in before this deadline. Here's kind of what works for us. Perfect. Then, so that's one of the easiest ways to communicate with the staff, because we will be handling the calendar. We will be handling a lot of times when policy is being done. You know, Senator Hoffman and whoever he's working with will come out of the office and go, hey, we want a bill that does X. Okay, then I carry that to our council, who are also very important and should always be respected. They're technically our lawyers and doctors who are the ones actually putting pen to paper, along with the revisor's office, to create what's going to potentially become a law. It's going to become what's discussed. It's going to become what's amended. So we're carrying that through. Then once we have all of that printed, then we get the jackets. And again, it's typically the legislative assistant or some staffer who is playing with those documents, who's making sure that the senator has them so he can get signatures. When it comes to working with a two-body system, like we have the House and Senate in Minnesota, we're the ones that make sure the green jackets, which are for the House, get to where they need to go, while the senator trying to take care of the yellow jackets. Sometimes we're the ones carrying those around. We make sure that they get turned in. And that's the only way to get them turned into a law, is making sure all your documentation is signed appropriately and reaches the right place. So that's just kind of a brief summary of all the different ways that we interact, from trying to get in with the senator to helping educate the staff as well, because once I'm engaged in something and understand it and how important that is, because there's a 80% chance I am probably carrying that and having that discussion with the people who are trying to turn this into legalese.
So let me add to that, Jeff and Richard. The rule of real estate, right? The three rules of real estate: location, location, location. In this case, and I'll highlight later on about my 7. I have 7 points, actually 7, 10, and 7 points of things that are important to this interaction. And it's just like real estate. In this case, in policy, it's relationship, and it's got to be authentic. So I'll go with that. So thank you.
I knew we would have this great discussion, so I'm ecstatic about this. But I want to I have to bring up one thing that I thought was really amazing when I started my journey from a pediatrician to this is, Kevin, how many layers of people are below you that screen things, and how many layers are above you to get to Senator Hoffman? I know I'm being facetious, but there's zero, right?
Yes, there is zero. It comes straight through me and out me.
Yeah. So I just think it's really fascinating that I think people who do not deal with the legislative process at all are intimidated by it. But I think the reality is, to get to John's point about relationship, it's really a very flat thing, and people sit there and go, should I write a letter? Will anybody read it? And the reality is, if you're in Anoka and you're in John's district, you're gonna, the Anoka area, you guys are gonna read the letter, right? Especially if it's a well-written letter, and especially if it's from somebody important. The other thing I want to dispel quickly, before we talk about, and then I think we should go to your point about relationships, John, is lobbying and lobbyists and people from the community. Can you talk about a little bit about, if a pediatrician from your district shows up, or a pediatrician from the academy, or the lobbyist? I mean, they all have some legitimacy, but can you, when you have meetings, what are you looking for in different folks when they come to see you?
I'm glad you brought that up, Jeff, because you look at it both from a perspective of, so whether it be a lobbyist or it be an expert, right? There's some key points that people should have takeaways on. And my first rule of 7 is really learn what's going on in your community. And your community is the Latin phrase, that communitas, right? It's the larger community. And because there's 2 things to think about. Number one, a lot of these organizations will do a y'all come. Anybody from the South here, you know what a y'all come is? When I first went to work at Frank Porter Graham Early Childhood Development Institute, it's the first time in my entire Northern life that I heard the word y'all come. We're going to do a y'all come. And it was Dr. Carol Trivet had said that, and it stuck in my mind. And this is when I was in my 20s. And I'm like, geez, what's this y'all come? She said, people put on these big, massive get-togethers, and y'all come and you discuss something, and y'all leave going, all right, this is great. And then there's no follow through, right? There's no follow along after that. So here's the kicker. So in Minnesota, there'll be a day at the Hill, a day on the Hill, a Capitol Day at the Hill, and everybody, y'all come together and y'all wear your little jackets and y'all walk around and y'all get, things going. But when y'all leave, then these lobbyists that might be representing the HMOs or the PHPs or the healthcare associates, they come and they're creating a day-to-day relationship piece with folks in the hallway, right? So when everybody's gone, who's the face that you see the most is going to be somebody that's representing that entity. Does that make sense? Because here's why. Learn what's going on in your community, the larger community, but there you got to develop your network. And here's where the first piece, the third point, is get to know who your public official is from a personal perspective. And then you develop that constituent relationship, right? Because it's important that you maintain that relationship. Let that elected official know that you're the local expert on whatever, right? But not in the sense of, I have, I speak Latin, I studied whatever. I have 3 PhDs, I have this, I have that. No, that's not the point. The point is make that germane to the argument that you're bringing or the thing that you're doing. Become that local expert, that go-to person, become that go-to person. And let me give an example, because that go-to person influences attitude and policy. I'm a brand new elected senator, freshman, and I'm sitting and I'm in all these great committees, man, because we were like, guns a-blazing, right? And so here I am sitting in health, human services policy, and housing policy, big. And everybody comes to the table doing their presentation. The administration comes in, and it's the first couple of days, and I'm sitting there, and not once did I hear anybody talk about medical home or coordination of efforts or anything. They talk about, oh, these brand new things we want to do. And all of a sudden my light bulb went off, and I shot back at the new administration, assistant commissioner and a commissioner. And I said, do you guys know who Dr. Jeff Schiff is? I did this, honest to God, I did it publicly. I asked the question. Jeff, you're laughing because you remember, because your phone started ringing after this. But I wouldn't have been aware of what Jeff Schiff had done and what Richard had done in Minnesota when it came to the Pediatric Quality Control Council and looking at children and youth with special health care needs and getting some really positive data that was there. I knew when they brought medical home to Minnesota and specifically started looking at it, that first population, there was good numbers there. I knew those numbers. You know why I knew those numbers, folks? It's because Jeff Schiff and I walked a long way, walked around. Jeff would always tell me about these numbers. So light bulb went off. Jeff wasn't in the room. I asked why he wasn't in the room. And I think it got back to him that there was some young senator, you know, asking all these questions. But folks, I wouldn't have had those questions. I wouldn't have had that light bulb go off if I didn't had that personal relationship with Dr. Jeff Schiff at the time. Does that make sense? And that's important.
I'd like to just briefly build on that. When we're like in the trenches in policy, for example, when we're handling our Health and Human Services Omnibus Bill, and there's several key pieces that I was in charge of on behalf of the chair and Senator Hoffman. If I have questions, if there's things that need to be changed, if there are problems, there was probably 5 organizations and a specific individual, each one, that I would call, which gave them the ability to have what was important and the influence to be directly adjusting policy as it's happening and be part of those negotiations through me, through Senate Council and the chair. So becoming that expert person where we go, there were several times John or the chair would be, hey, have you checked with this person yet, just in case? Let's get their eyes on it, right? Like, rather than, we're not just running a head bull in a china shop, we want to make sure it's right? So we have people that have developed those relationships with us where we're like, all right, Maren Holden from Disability Law Center, what do you think? Can you give this a look? It doesn't even necessarily do anything with what they've been specifically advocating, but we know their knowledge and experience is valuable and we want their eyes on it. So just to stress that meat and potatoes when you're in the process, how important that relationship can be. Once a legislator or their staff calls you for advice, you know you've hit that point.
Let me back up on that one, Jeff. Can I? Unless you have a
Sure.
follow-up.
No, go ahead. You go, and then I'll say something after.
So there's a margin. I call it the Marge-Mann effect, and we're talking about becoming that local expert. Fill in the blank. Local disability expert, local maternal child health expert, local whatever it is. You then influence attitude and policy. Years ago, I came back to Minnesota and there was I can't even remember what the bill was, but we needed the signature of a state rep, right? There's 201 legislators in Minnesota, so get to know who they are. And we needed this state rep signature on this really thick bill. We pulled him out of his committee. He was the minority leader at the time. We pulled him out of his committee and we started to explain to him, we really need your signature on this bill, and here's what it does. And it was the deprivation and aversion. Apparently, at one time, you could take kids with disabilities and lock them in rooms, in padded rooms in school buildings. So we wanted to get rid of that, right? And it was really not a healthy thing to do. Started to explain to him, and he stopped us and he looked at everybody and he said, "What does Marge-Mann think of this bill? What does Marge-Mann think of this bill?" Bob Brick, who Jeff knows, said, she loves this bill. This legislator said, anybody got a pen? He reached for the jacket that he needed to sign, didn't even read the bill, but he asked the key point, what does Marge-Mann think of this bill? And it was, she loves this bill. He signed it and handed it back to us. We walked away. Key point was, there's credibility and validation in somebody that he knows within the industry that we were advocating for back then, and that one made it. So with that, Jeff, I'll pass.
So I want to keep this going, but I want to just take one step back to tell folks that if they have questions, and I know some have started to appear in the chat, that would be great, because this is not, so we can expand this dialogue some. And then Rich and Heather, if you would sort of moderate and jump those in. I want to just say one other thing, just as a level set for this conversation, John and Kevin, is that we have a lot of experts on this call who are at least as knowledgeable as I was in Minnesota. So I really want to give a lot of folks credit, including parents and care coordinators and administrators and pediatricians. So I think it's really important that being an expert doesn't mean you know the physiology of calcium metabolism. It means that you have that you have lived experience and you're willing to keep with it. I want to go, but John, I want to, you're laughing.
It's funny. No, because you're right on, you're spot on. It's not, I don't, I don't care how many acronyms you have after your name, Jeff, but if there's a credible, reliable, authentic relationship there and you happen to be a person that is trustworthy, boom, done. Have a nice day, right?
Yeah. So I want to go back to, I want to circle back then, if this is okay with you guys, and talk about this, how to build a relationship thing. And you had your 7 points that I think it would be great to start to go over. But before you do that, I just want to say to everybody who's on this call, I think the coolest thing about this is that it's really accessible, and I got to tell you, it's sort of a gas when you get to know a senator like Senator Hoffman, or I can name a bunch of other folks, and you start to know them a little bit, and they become the person who is sort of, you become somebody who they can trust and call, and you know that you're going to be in the process. And, as Kevin said, when these things get jacketed, which means that there's actually legislative language at that point that starts to go, you have to, that's when it's always fun, but it's fun to be in the middle of the soup at that point, because when somebody says, and we were in an state agency, would always joke around about may versus shall. May mean it was optional, thanks a lot. And shall means, holy crap, somebody's going to hold us accountable. You know what I mean? Or, if we had the option, I would actually sometimes want to have reports written, because I knew that a report going to the legislature would mean that the agency had to commit resources to it. So I just think that some of those nuances you can learn very quickly. They're not rocket science, like calcium metabolism, can be. They're about being persistent and having ingenuity around that. So I just want to say that, try it. Try getting to know your local legislator or the chair of the committee or something like that. They are really accessible, or more accessible than you think. And I suspect even in populous states, they are as well. So John, can you talk about this relationship stuff in more detail, so that folks can get a sense of both how to do it and what to do?
Yeah, I think there's a couple things. First of all, you're a constituent, right? I mean, that's first and foremost, and doesn't matter what your label is at that moment. You are a constituent. This person is in office representing you and how many ever, thousands of other people that are in there. And that's key. There are some legislators who refuse to meet with people that are not their constituents in offices. That's kind of the first thing that usually comes out. And where do you live? What's your address? Where do you, those things pop in. Our office isn't like that, but there are a lot of offices that refuse to even allow people that are not constituents into their fold. But here's the thing I think that is huge is, whether you're a parent or you're this or that, right? What's going on in your community. You're the ground level person for that legislator to know what's going on in your community. And your community is defined by whether it be, the regional, geographic, or whether it be, the categorical community. Doesn't matter. The fact is, you then know what's going on because you're learning what's going on in your community. You then become a liaison. And I use that all the time, Jeff. If somebody sends me an email or a letter that says, did you know that the widgets are da 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 da? And I'm like, no, I didn't know that. But you know what? Would you please, keep me informed and let me know if this comes in front of us, that I should be aware of that. Kevin, we use that all the time, right? Because there are so many things that I don't know about, i.e., I can sit all day and talk about education law. I can talk about how it interacts with human services and health and whose jurisdiction is what, right? But man, Jeff, when you start getting me into TIF tab, transportation infrastructure, how the, rate methodology works within the tax accreditation on X, Y, and Z, or that over my head. But there are people that know that stuff, right? So learn what's going on in your community, right? And then within that, you also have developed your own little, it's kind of like the John McKnight. You guys know the concentric circles thing, right? I mean, those of us that, John McKnight, you start with you, and then you go to your informal supports, and then your associations, right? So then developing your network of friends and families, and who within your network understands your community, right? Whatever that community is that you're defining. That brings a sense of, oh, I should be listening because this person knows and is speaking on behalf of the American Engineering and Testing Company, right? That happens to be in my Senate district. So that piece of it opens that doorway to an elected official going, there's somebody there. Then get to know that public official. Take them out for coffee. I love meeting folks for coffee, right? I mean, that is like, there's never enough coffee in the day for me. So there's, but believe it or not, Jeff, the ADD, just kind of kicks in, and it's like, the coffee slows it down, but there's never enough.
Man.
Self-medicated man, and coffee is it, right? So find the best coffee place you can, and sit and have conversations with people, because you're then there. So get to know who that public official is. Introduce those public officials to who you are in your family and your life, right? There's a sense of vulnerability there, because a lot of people are saying, well, can you trust that? No, but the point is, what you're doing is you're getting embedded this Marge Man mentality, right? Why did this elected official, the first thing out of his mouth to all of us that were pushing for this bill, said, how does Marge Man think of that? Because she got to know who the public official is, right? Then that embeds into the piece on the developing the constituent relationship. You become that go-to person because of the fact that you've developed your network. You are that person, right? And then you're maintaining the relationships, and maintaining the relationships isn't, texting every 5 minutes or whatever, but it's periodically checking in just to say, I'm here, right? I'm here. Pop in, drop a card off, drop your Mother's Day card off saying, hey, great job. Let's do, I mean, it's just that kind of networking 101 piece in there, right? And which then comes back to, now that elected official has built that relationship with you, knows that you are now that local expert. When if it's disability that's related, then you become that local disability expert, right? And just by that itself, Jeff, like Kevin had talked about, there are go-to people that we have. Then you become that person that's going to influence attitude and policy. And I think that's important. So that first 7 key points really, really fall into play there. So.
Can I ask you, I'm just going down this road of you have some interest and knowledge about this, but somebody else in the legislature, I used to say we had a 201 member board of directors at the Department of Human Services, and only three of them knew what we did. You know what I mean? So I guess the question is, so we're asking this group, we're suggesting to them that they write a Mother's Day card, that they develop a who, a what data, and an ask. And I think that for you guys who are jacketing the bills, who are going to carry it, who are going to look at the maze and the shells and the reports and all the nuance, that's the relationship stuff you need. But there's also the other folks who may just need to a more, I could say, cursory may not be, I don't want to be condescending, but a less detailed bit of knowledge, because they're not going to carry health bills for kids with special health care needs like you guys might. What do you think about the ways to communicate with them? And maybe you can even take a parallel from something that you're not expert about, but that gets dropped on your desk because it's in one of your committees.
Yeah, no, Jeff, that's important. So once you've developed that first key 7 points, right, when you become the person of that has that authentic relationship with the public official, right, the piece about influencing attitude and policy is also educating somebody in that, right? And it's, we look at 201 legislators. The first thing I have an intern do and is, we have our interns when we had what, 5 this year, Kevin? Did we have 5? 4. Anyway, we had our interns, and I had them do backgrounds on every one of the elected officials, right? Because I was trying to find out from our office standpoint who our go-to person was going to be over in the House. Who's that somebody that understands about anything, right? Whether it be in transportation, or in this case, it would be health and human services. And that's a great exercise to do. So key point is do your background, do Google search a little bit, right? When I came back from the hearing and Kevin's like, yeah, this guy named Bobby Silverstein called, and I'm like doing backflips because I'm like, Bobby Silverstein, right? And then I said, look him up, man. And so Kevin looked him up and went, oh my God, right? It was like, it's just amazing. Talk about somebody who influenced some laws in Minnesota. But my point there is that you're influencing policy and attitude just based upon the relationship piece of it, right? That's key, Jeff. That's huge.
So I think what I'm hearing you say is you can do the education, but you have to do the relationship at the same time.
Exactly. You just don't. And here's the thing: University of Minnesota. This is what. When I served on the Legislative Citizens Commission on Minnesota Resources, we were charged with giving $52 million a year out for programs that had to deal with, energy conservation, clean water. Right. It's a small pocket of money in the larger scheme, but it's very concentrated. And the key was there was experts in the room, and there were also legislators on this committee, and we decided where this money goes, right? University of Minnesota, I'm sorry if anybody's from there, but I had started doing a little digging because one of the researchers came in and got really kind of schmarky in the committee and very arrogant. And it was just really standoffish. It wasn't authentic, right? And so I started digging around. And I found out that they had $17 million of unspent money from this committee, and they were actually taking money on the earning interest on that money. And so at the end of the day, it was like $868,000 of interest that they had racked up that should have gone to the trust, because this money, LCCMR, is Environmental Natural Trust Fund, and it should have been part of the trust. So I just raised a question in the committee: what's the U doing with all this money? And they just got really defensive. Man, that defensive and that schmarkiness put a brick wall up between them and the committee, and it took a while, right? Where there's a little thing about vulnerability and humbleness that comes into play here too, that it should have been there. And so my decision to really dig deeper was the fact that this person was really putting up this real brick wall of I'm smarter than you. And he came across that way, right?
Mhm.
Yeah, you're smarter than me, but at the same time, this committee is going to determine whether or not you're going to have any funds. And so, not to be arrogant on that, Jeff, but sometimes humbleness and humility, I guess that's a term I can use in jointly, is comes into play in this. But then, Jeff, that comes back down to the authentic relationship, because you and I have had some really great discussions in the past, right? And you disagreed with me. I've disagreed with you. We've, how does this roll out? But here's the thing: I didn't personalize, and you didn't personalize. And that's the other thing, is you can't personalize, because this conversation is not about you and it's not about me, but it's about what am I trying to get across to this elected official, or what am I trying to get across that's going to influence attitude and policy.
Yeah. Well, maybe we should go talk about your colleague on the other side of the aisle for a minute.
Sure.
Talk about personalization. So I just think it's important, because I think one of the reasons I wanted John on, and I could have had Jim Abler, who's the guy on the other side of the aisle, on as well, is because you don't always agree on everything, right? And you have to find common ground to work with. And sometimes that common ground is far from partisan, and I think we live in this world where you can pick the partisan fight up every day in the newspaper, right? But that's not how it really works, right?
Yeah.
It's how it really works is people who are trying to do, on both sides of the aisle, trying to do something good for the citizens they serve, who want to have good results. So, John, talk about for a minute, or Kevin, talk about, how you find common ground. What do you do? Where, how do you advance that? Because a lot of that stuff never makes it to the newspaper, right? The maize and the shells don't really make it to the newspaper. They really make it to say, okay, this is acceptable for everybody. We know we're going to spend money on this population. How do we spend money better?
Yeah, here's the thing, Jeff. Channel 5 ABC affiliate, we did this panel 3 weeks ago, and the question was asked to me from this reporter saying, what's the biggest barrier in politics? And I said personalization. I mean, and I gave some examples of that, right? That you got 201 egos and they're all about me. Listen to how somebody talks, right? I, me. Kevin and I have this conversation all the time. We listen to what people are saying and how they're saying it. So here's the thing is if somebody can set aside that personalization side of it, because this is not about them, but rather it's about the collective. It's if you're really truly driven by the policy stuff of this and truly want to get something done, you do that and you find your allies that are going to be there. It just so happens, Jeff, 94% of the bills that I was on this past session, 94% are bipartisan, and that's a 2-year session, 94%. And that's just how we operate. I think, Kevin, we're on 200 and some odd, 235 bills, and our hit rate's really super huge. And the relationship we have as the lead on Health Human Services finance policy reform underneath the chair, who's Senator Jim Miller, who happens to be a Republican, and he lives 3.6 miles from me north. He will be the first to say, John's a Democrat, I'm a Republican, and then he yells, so what, right? Goes back to what former Congressman Jim Ramstad taught us. And when I was part of the Federal Interagency Coordinating Council under the Bush administration, Rammer used to always say, can you leave your ego out in the hallway when you're talking about health and human services and education and really focus on pragmatic, what's right for the desired outcome that we're looking for, and be, the whole thing about common sense comes into play. That's missing. And so I'm able to, Jim Abler and I are able to work together because we know that there are 3 or 4 personal things that we will never discuss and never debate because of where he's at or where I'm at, right? He jokes about one of them. I say raise taxes on the top 1% even higher than what they're doing, right? And he jokingly will say that publicly. Well, Hoffman's solution to more money in education is just raise taxes on the 1%, and then I'll shake my head. Yep, I agree, right? That has become just kind of a funny little thing. That's because he's not personally attacking me and I'm not taking it as a personal attack. Rather, this is just something that we are opposed to on 2 things. But when it comes to everything else, Jeff, we work so well together, and it's noticed. It is noticed across both bodies, the House and the Senate, to the point where Kevin was referred to in a meeting as Senator Abler and Senator Hoffman's legislative assistant. So now he works for a Republican senator, and joke about it. It's funny. Multiple times, Jim Abler would come down and he would stick. My door's always open. I never shut my door, Jeff. Right, unless it's like data privacy conversation. But my door is always open. Abler comes in, starts talking to Kevin, doesn't even say hi to me, just starts telling Kevin, this is what we need, and out the door he goes, right? And they were off doing their own thing. You know why? It's because Kevin became just this huge valuable asset to the committee for the greater collective work. And because of that, Jeff, we've had the best health and human services bill in 23 years in the state of Minnesota that Jim and I have ever seen. But here's the sad thing. When it comes to who is the knowledge base on that, there's really basically 2 people that really understand the world you live in, really truly understand it, and that's Jim Abler and me. So but it's important. You know that.
But I think the other thing about the knowledge base is you could, I mean, I'm going to say something that maybe you'll agree with or not, but you could, if you spent a day or a week or some relatively short amount of time, be fairly knowledgeable about where a specific aspect of law is, and especially if it's something you're passionate about. It doesn't take, I think the thing I'm really trying to say to the folks here is it doesn't take you, to be the expert doesn't mean you have to quit your day job. You know what I mean? You just have to translate your day job into some of that relationship stuff and some of the legislative language as well, I guess is what I'm really saying.
It's real correct. Absolutely. It's correct. It's it's day-to-day interaction, Jeff. You're absolutely correct on that. Yep.
I want to go to a question that was in the chat a little while ago from Nick Claxton. He's, I think this gets into a question that I'd like you guys to talk about a little bit more, and we're a little bit circling back, but how is someone important defined? And I think what we're talking about is who can show up and like how to show up. And I think that's one of the thing, I guess that's that intimidating thing. And I've been on the side of this where, you get 12 people to show up in your office and then you got to pull in chairs from outside or whatever, or and you script who's going to say what at the right time and all that kind of jazz. And I don't think it's not unimportant to be succinct, but I think it's important to figure out, is it better to show up all together with a nice ask and a relationship building and coffee? Is it better to, how do you sequence that whole thing if you're brand new at this? Is it coffee first and legislative language second, or doesn't it matter? It's just about being authentic.
It depends. I mean, it really depends. If you've done your homework on who that individual is, right? Because there are a handful of legislators that no matter how you come to them, they're just going to be hard to get to, right? But you need to, it's like that BATNA, the best alternative to that negotiated agreement that people are always talking about. So if you've done your homework and you know who you're going to, then do it. For example, Jeff, I had folks that, when we would have large groups of people come in and sit down, or even, I'll give you one prime example, was this brand new spanking year, the committee that we're Kevin and I work on, of a $52 billion budget, our jurisdiction is roughly 16 billion, right? And that's huge when you talk about what is your jurisdiction, and this is, little babes up to grandpa and grandma, and this is birth to death, basically, in health and human services reform. So here's this brand new, and staffers come and go within state agencies, Jeff, but even their inability to do a little background, then I'm not talking to a skip trace background search, but really, just kind of go and do who right? It's kind of like when we first met, right, a few weeks ago when we were talking about this, right? And you said, and Richard said, I don't know if you remember me, John. I was like, do I remember you, dude? You came to Minnesota. I knew, because I had remembered and recalled just all the work that you and Richard had done for Medical Home, right? It's that simple. So do a little bit of background search, and I'll give you an example. Brand new director within the Division of Disabilities within Health and Human Services, right? And Jim and I are pushing, Senator Abler and I are pushing DHS to get away from this 84-16. They say, well, 84% of a change, it's good. 16%, we just have to, we know it's going to people are going to fall through the cracks. That's not okay. Those statistics are terrible, right? That's not a systemic approach to looking at how policy should be changed. And yet they're pushing on the backside saying, well, CMS is saying we have to do this. No, CMS doesn't tell you to say anything. They just whether or not approve that this matches what you're doing, right? You've seen one Medicaid plan in a state. You've seen one Medicaid plan in a state, right? So here's this brand new administrator that's on this call, and there's Kevin, do you remember this call? The two of the legislative liaisons and the finance person, and then their division, and Abler and I are pushing, saying, have you thought about it? It's asking those bigger questions. Have you thought about what about, right? This how is this going to look? How's this going to do? And this guy decides he has to pipe in because he's brand new, right? He decides he has to pipe in. He said, well, I really need to respond, right? That was his biggest mistake, Jeff, when he said, I really need to respond. And then he started to educate Senator Abler and John Hoffman about how Medicaid works from the national perspective. And I had to cut him off, Jeff. I wasn't being, but I'm just like, dude, we're not even there. We're digging down this rabbit hole over here. But Jim and I understand waiver services pretty good, right? So it's okay. Then that wasn't enough. Then he had to follow up with, well, under our current way we do waivered services. And this guy's a doctor, right? He's a PhD. Well, he's not really a doctor. He's a PhD. So he's a philosophy, doctor of philosophy, but PhD. So he decides he has to pipe in again and tell Jim and I that this is the worst thing you ever want to say to me. Well, parents can always appeal the decision, right? At that point, Jeff, you know what my response, the old response would have been, right? I'd have jumped through the TV and said, dude, get your act together. But I just paused and I said, why is it that the burden of proof continually falls on parents? That's not a systems approach to anything. You guys should be asking these questions and thinking about it. So instead of them asking the questions, you know what Abler and I did? We turned around and said, all right, Kevin, this is what we're going to do. And we wrote language within law that says, no undue burden, no. I mean, we started putting language in there that says, and it's not permissive language, Jeff, you shall, right? It's not the you may, but rather you shall. And Kevin actually got to insert, this one little sentence in this one to protect families because the system wasn't looking at it from a systems approach. We had to garnish that. Now, coming back to your thing, why did we know that stuff is because of our relationship for years with people like you, Carolyn Allshouse, folks like that who understand, how the system should work or could work. So does that make sense?
Yeah, no, I think it really does. You get at a point which I think is really important, and you'll live it when you're both at the legislature and in administration. Everybody here lives it. Obstruction and barriers and burden are not partisan.
Right.
The egos, you talk about leaving your ego at the door, people, people want to maintain the position they're in no matter where they are, and they're going to act to be an expert, whatever. And I don't know. I just think it's, I was just thinking as you were talking, I learned a lot, and I suggest this to a lot of people, that you should listen. You should ask questions and listen first before you offer your information, because there's no downside to that. And you can learn about what John Hoffman or Kevin Parker thinks is really important. I want to ask about the ask, because one of the things we're doing here, with this group is really helping folks refine how they go in their states to their legislators or their Medicaid program or their HMO. So it's not always the legislature, and do an ask, and I think that, Kevin, you made a reference to this early on, so maybe I can start with you on this, but, an ask isn't like on line 23 of the 256B section, whatever, can you change the may to a shall? It could be, but I think that people get confused. They either come in asking for world peace and say, can we just totally fund something? Or they come in asking for a very specific thing. And I think it really gets to what's the level of ask that really works with you guys, that you can then take it to the committee administrator or to the revisor's office and get something done. And you can also shop it around to make sure that the pediatricians aren't opposed or the disability folks aren't opposed. So how do you get when somebody comes in? And then if you could just add to that, I just want to add this too, a little bit about timing, because now we're in the summer. This is not a bad time for this kind of stuff, but in December, it's really a crappy time, right? So if you could just talk about those things, that might help folks as well in other states.
It's actually funny you brought that up, because that's what I was going to start with regardless, was first your timing. Because what can you expect to get based on when you're approaching them? Like, yes, you're correct. During interim, save when people are on vacation, that's a great time to start scheduling something to at least get that basic information out there. If you want to I have become a fan after 3 sessions of always trying to prep things earlier rather than later, because you still have everyone who comes up in December or January with either legislation that they didn't discuss all summer, even though you already printed it and had it dropped the previous year, because at least in some places, Minnesota, we have a biennium. So it's a 2-year system. But if you drop it off the radar and don't communicate with us at all about it during the first interim between, then it's not going to be highlighted in our minds. So when you come February or March and say, hey, we really love to do this, well, we don't have time for it. And to give you an idea of what some timelines are, because various state legislatures are dramatically different. Minnesota, we have pretty much January through May, and then we can have special sessions as needed. Other places convene as they need, but learning how they function and what their timelines are. For example, I can, referencing Minnesota, if you come to us with something in January, it is not hopeless. Even February, it is not hopeless. It's harder. And so you'll have to understand that the later you get in the process, the smaller your ask really needs to be to reasonably get done. If you want something world shattering or you need a lot of funding, granted, there are some caveats to that. If you're really good friends with the chair, or like there's pieces that essentially cheat the system that is based on relationships. But if you come to us January, February, we can do something. But we start hitting our deadlines usually in March is when we start hitting our first and second and third deadlines. And there's different, without taking up too much time, the simple is there's certain goals a piece of legislation has to meet by each of those deadlines before that's it. So the bigger and people, as I had a much closer view of negotiations this time around, and looking at how people are comfortable or not comfortable with something really comes with how much does it affect them and how aware are they? And if they don't feel comfortable, if there's a phrase we always heard, well, I'm not the expert. Well, as much as we make fun of that particular individual, at the same time, it is important that someone helps make them the expert before it comes time to vote, to do those final negotiations, so that they can't say they're not the expert, right? That way they're like, I do understand this and I do support it. Because if you start getting to the last month of negotiations and they're like, well, no one really approached me with this and I have no idea what it's about, I don't feel, you'll hear that, I don't feel comfortable voting on this year. Then it dies in conference or behind closed doors. So the sooner the better. If you can catch someone before legislative session to at least get the basics of what you're talking about and even start forming the language, the better. If you're starting into like a legislature that has a spring, kind of winter spring type session like Minnesota, catch them in the first month. That's going to be your best bet to have enough time to get someone to buy in, help you get it printed, get it dropped and signed, and then educate everyone in the process who needs to be, because that's when you have to start identifying, your authors in the House and Senate, your author, who's going to support what committees they're going through and whose votes do you need? Can it make it to the floor, etc. So the timeline is absolutely important. I would say just a couple rough examples of things that even getting through, we had a very simple one come. It was like end of February, my first session, a maternal Mother's Day, mental health Mother's Day, which we ended up getting passed, but that took 3 sets of email chains, 3 personal visits to the CA. This was just one of those side projects that got tossed at us from our Speaker of the House. And so I had to build a relationship with the CA, and then it turns out it didn't go to the committee that it originally went to. It went through Health and Human Services through a side route, because as you'll learn, there are rules of how things typically go, and then people just vote and change those rules for individual pieces because they want to. But it got through. But that was it was a paragraph just detailing that this specific day is, or this month was Maternal Mental Health Month, to respect mothers who are going through, postpartum depression and things like that. So that was a relatively small piece. It took a lot of effort, and I had no idea it had passed until the very end when the CA had tipped me off and was like, oh yeah, I ended up sliding it over to the other CA in the other committee. That was really small. Getting significant size pieces takes a whole lot more effort and a lot more time. While miracles can happen and tricks can be pulled, the earlier the better, and accept that when you're educating one legislator, by the end of the process, you'll probably have to educate at least 5 to 10, minimally, if you're getting them in the right positions. And that's chairs, authors, even leadership, if you can get someone in leadership on, again, various sides of the aisle, if there's 2 bodies, etc.
So, Kevin, thanks, because I think that timing is really is really pretty crucial. And I was always impatient because I thought, okay, I'm never going to get this done. And, and then people would say, oh, we'll do it next budget session, which means it was 2 years away. So sometimes you do a fire drill ahead of time because you don't want, you're impatient. John, can I ask you about, or Kevin, I like what you said about, the dropped and signed, which is that there's a bill that gets put into, it gets a number, right? It gets put into the hopper. There's every state has something, some different terminology. It doesn't have to be perfect when it gets there, but it's sort of like your first draft. And I always think you start off, and I have an example in the slides we'll show a little bit later, with a set of priorities. And then those priorities get written into legislative language. And then a bunch of people say, no, we want this instead of that. But, how often do you get the priorities in the shape you want them when you talk to folks? Or how can folks do that? Because in this group, it would be like saying, we want a care coordination payment as part of a value-based purchasing program, if one exists, or we want a care coordination payment that becomes a Medicaid benefit. And, or we want, or we want a study done about how to adequately finance primary care in pediatrics to do this. And the study has to do X, Y, or Z. I think all those things are like examples, but they have to be fairly solid to get written, right? So you want to show up with your Mother's Day card with a thing that says, okay, Kevin can take these 5 bullets and send them off to the revisor and say, we want to drop a bill about this, right? So talk about that translation.
So Kevin, why don't you give us some examples of where, Jeff, exactly what you're saying. Somebody has come with an idea, and I'll just say, send us a paragraph about what you want, and from that moment on, we send it to council, research, and revisor, and it's done. I mean, it's that simple, Jeff. I mean, it's there are people that forget more in a day than any of us will ever know when it comes to how these words are going to fit within some statutory realization, and that's not your piece. Your piece is to give us the idea, right? What is it that you want to say? What are the key points that you want laid out? What is it that you want folks to understand, and how do I refine my objectives and expectations? Get that off, and then we go from there. Kevin, give some examples of where that happens on almost a daily basis for you and I, correct?
Yeah, so, and especially lately, especially with Zoom meetings and things like that, I've taken to sitting in more meetings, because my first year I would be at my desk, John and lobbyists, constituent would come out and be like, we want X. And then they're out the door and I have to go, I'm going to do my best, or have to pause it and circle back later. So now I sit in on the meetings to help be able to see what the point and intent, because that intent and the reason for the legislation is also important. Why are we bothered getting this printed into something that could become law, right? And what are you going for? Then typically I'll take it, and there's 2 pathways. If it's in our main committee and it's something important, so Health and Human Services reform for us, I'll go straight to our council, usually Liam Monahan, who is fantastic and amazing, and you always respect that man. And you'll work more closely just because you have that route for them. If it's something more general, then we'll go through the revisor's office. And I think it's interesting to note is, as you develop a relationship with your legislators, that also can give you access to those additional staff beyond just myself. For example, we've had several people and organizations, when we know them well enough, they'll just ask, hey, can I have permission to work with, the revisors or this specific council member? And if John gives it, then I'll have them CC me so that I'm still involved in seeing how things progress. But then they have the direct ability. So it saves me from having to do some back and forth sometimes when we have that ability. They can see the intent, the language, and the words, and be working directly. And then I'm more of a moderator going through to see how this comes out. But once it gets through the revisor, once it gets through the council, usually I'll have Senator Hoffman give it the final look. And then it's like, okay, go print it. And after that, it becomes moving.
Awesome. And Kevin, I'm just going to say moving means that it goes from, it hits the committee if there's a hearing, and it, and it hits the House and all those sort of things. I want to, I'm going to start to wrap this up because we could talk for a long time, but I think I really so appreciate you two coming on and talking about the flavor of this and how to make it successful. And I think the other thing I'll just say is, Senator Hoffman and Kevin, I think you gave us the sense of sort of how exciting this can be. You know, it's not like this is, you know, there's, you know, I always think that, you know, at a good day at the legislature, my bill gets passed out of committee. It's such a dull thing, but it's like, yes, you know what I mean? It just goes off to the next step, and then it goes off and it gets put in the omnibus bill. And then by then it's like rolling, you know, there's like no, you know, it's like a boulder going down a hill. It's not going to stop. So anyway, I want to spend just a couple minutes framing what we're going to do next. Kevin and John, you're welcome, if you don't mind, to stay on for a few minutes so we can just talk while we take a break, if you have a sec. But I want to go and just switch over to sort of what we're going to do for the rest of the next the next couple hours with Care Coordination Academy. So if Heather, will you go to slide 18? I think it's this, it should go to one more, I think. Yep, one more after that. Nope, there we go.
Sorry, I can't see numbers when I have it large.
Oh, sorry. Just go back one. Okay.
Go back one.
Yep.
There.
So, so everybody, I'll remind you that we used the iChirp, which was a program for birth outcomes for high risk pregnancies, and they had developed this Mother's Day card, this 2-pager, and had a 2019 platform that some of this got accomplished, especially sustaining funding for them. But they had these really very clear things as part of the ask. So it was support standalone, iChirp, through multiple community-driven partnerships. I won't read all these because they're not really, the specifics aren't really relevant, but the level of ask is, you know, drive systemic changes in clinical settings, you know, advocate for expansion of efficient and effective services. Some of these things could get written in as specific funding, and some of these could get written in as we should study how to do this kind of thing. But this was the ask that they had on the 2-pager, which is earlier on in these slides. The other thing then, if you go to the next slide, Heather, is they had a bunch of they used some quotes. And I thought the first quote was really one that would hit home for legislators. I'm going to read this one. It is hard for American healthcare professionals to get their heads around that when you have an organized community-based team that connects technical clinical issues with deeply embedded set of relationships, you can really make breakthrough. So that's the positive quote, right? You know, and the quotes are positive here. I wanted to say that as well. If you could go to the next slide. So today we really wanted to, last time we spent some time talking about who you are and what you do and who you're presenting to, because not everybody here is presenting to legislators. I want to be clear about that. And you may still need to spend some time in your teams talking about that. But we also wanted to say a little bit here about, take some time today talking about these 3 things. The first is, what's a personal story or quote that will really hook in? What do you need to do to have a relationship? And John we spent some time talking about the relationships with the 2 or 3 people in this board of directors that know this well, but how do you want to do the relationship with somebody who doesn't, so they start to trust you? What data do you want to present, either national data or your local data? And I know there's a lot of work in these groups talking about that. And then the next slide, we talked about what we've spent some time talking about now, which is what's your ask? And remember that the first ones are informing and listing commitment and expanding who's involved. And then eventually it's around money and legislation, et cetera. So I want to just talk about that, or ask you guys to talk about that. I think this is both art and science, I guess. So we'll ask you to do the art in your groups. And then Heather, I think what's happening now is we're taking a break, right? And then people are going to go back into their own individual groups. So with that, I'm going to say two other things really quickly. I want to just echo what's been in the chat around Carolyn Altshouse, who's been a dear friend of mine and expert from Family Voices in Minnesota, who John knows well, and I think Kevin knows, and I certainly had the pleasure of working with from that perspective. And then I want to again thank John and Kevin for being part of today's session. It's been invaluable. So back to you, Heather.
Yes, thank you so much, Jeff, and thank you so much, John and Kevin. That was excellent. So now we will take a 15-minute break. So I'll ask you to return at 1:30. And as always, I pull Thomas into everything I do. So this is my son, Thomas, now. He'll be one next month. So feel free to go ahead and take a break, and we'll see you back at 1:30, and we'll go to team breakout groups.
Heather?
Yes. Hi.
Why don't we repeat the announcement for teams that joined late about the continuation?
Sure, go ahead.
So I recognize that some people might have joined a little bit late, so you might have missed our announcement. We have some really exciting news to share. There is some additional funding to continue the Care Coordination Academy through at least the end of May of 2022. Stay tuned for additional email announcements about this, basically continuing the journey towards sustainability. So there's going to be this theme, as we talked about, implementation, measurement, sustainability. So for those of you that joined late, wanted to share that good news, and details are to come. We'll reinforce that point at the end of today's session as well. And I just want to throw my gratitude, Kevin and Senator Huffman. Thank you so much. And I'm also a card-carrying member of the Carolyn Altshouse fan club. Carolyn, I wouldn't be who I am without all the hours you and I have spent in airport waiting rooms, in classrooms, and just saying, you know, Rich, this is what's important. So thank you, Carolyn. This is it's intended to have your DNA all over it. So thank you.
Thank you, Rich. Okay, everyone, so it's 1:30. We're now going to move on to breakout groups. So what we'll be able to do is you'll have the ability to do the self-selecting breakout group option in just a moment. I'm going to load all of the groups. As long as you're running the most up-to-date version of Zoom, you should have no trouble assigning yourself to your group, but we are here to help you if you need to be moved manually. Let me go ahead and open the breakout rooms. Okay, so all the rooms have been opened. So what you'll do is if you're running the most up-to-date version of Zoom, you're going to go down to the participant list. And once you and everyone in your team are ready to go ahead and move on to your breakout group, you'll be using the instructions that I sent out via email. I sent them out last week, and then I also sent them out just before the meeting. So they should be at the top of your inboxes. And I think just one person, the team lead, ideally, if you can bring those instructions to your group and be able to go through the questions together. While you are in your breakout groups, if you have any questions or you would like someone from faculty to come into your breakout group to assist you, you're able to chat the host, which is me, while you are in your breakout groups. I will then come into your room and see what are some of the questions that you have and then determine who might be best to talk with your team. If our faculty is available, they might be in other rooms. We'll try our best to get them around to everyone. If we're not able to get them into your breakout room today, we can talk further through email about how we can best support you. Let's see, does anyone have any issues with their breakout rooms? And if you need to be moved, just go ahead and put your name into the chat and just tell me where you need to be moved. All right, I'm going to go through and start assigning you all. So as long as it'd be very helpful too, if your beginning of your name has your state abbreviation, we can move you super quick. Let's see. And Erica, are you on? I can make you a co-host right now so you can help move people around.
Yes, I'm on.
Perfect. I'm going to make you a co-host and then you can just help me kind of move people around.
Mhm.
Thank you so much.
Sure.
All right. And once you should be getting notifications as we move you that asks you to go to your breakout rooms.
Hey, this is Katie Kaplan. I can't seem to type anything. It's not letting me type in the chat or change my name. But I'm with the CBH Philly PA team.
Yes, I will move you. I don't know why we have you so restricted, Katie. I'm sorry.
Yeah, that's okay. Usually I can type. It's weird. I don't know what happened. Thanks.
No worries.
And this is Elizabeth Lawlisher, and I need to be moved to the Montana group, please.
Elizabeth.
I got it, yeah.
Thank you. Okay, and if you are running the most up-to-date version, you should be able to move yourself too, but if you're having any difficulty, that's why we're happy to go ahead and move you.
Yeah, this is Dave Miller from Michigan. Can you move me to that group?
You got it.
Thank you. I have to join on a browser. State of Michigan doesn't like us using the Zoom application.
Okay.
This is Tina Olson. Can you move me to California, please?
Sure.
Mhm.
Dave Miller, did you say Michigan or am I mixing you up with another M state?
No, I'm from the Great Lakes state.
You got it. All right, sending you over.
Meredith Byrne, New Jersey. If you can move me, please.
Sure.
Got it.
Thank you.
So same for Steve Carey's.
New Jersey. Sending you on your way, Steve.
All right.
Thank you.
This is Erica Jewell. If I can go to California, please.
I got it.
Thank you. All right. Is there anyone else that needs to be moved? Our list is starting to go down. Let me know if anyone needs help still.
This is Kari. I would love to go to Team Minnesota.
All right. And we're sending you on your way.
Hey, it's Renee Heather. Can you put me in PA?
And there we go.
Thank you.
And Heather, this is Steve Fitton. Can you put me with Michigan?
Yes,
got
we will.
Thank you.
This is Mary Glazer. Can you?
Recording. Okay, so they all have 50 seconds and then the breakout rooms will stop. So they should all come back. All right. Welcome back, everyone. I think everyone's going to be returning slowly. We have about 15 more seconds in the breakout rooms, and then they'll be closed, so everyone will come back to us. All right, so everyone should be back now. Thank you. Sorry for the little technical difficulty getting you all to your breakout rooms, but I hope you were able to have some good conversation. What we will do now is similar to what we did last time and have a team report out and discussion session. This is not meant to be very formal. Feel free to turn off your mic and come on and just kind of talk about what was going on in your breakout rooms. This is a great time to, if you have any questions that you want to ask that would be helpful for the rest of the group to hear together. And anyone that wants to go ahead and go first, you're welcome to. And what we want to focus on is what you talked about today regarding your data and your ask on how you will put this together in your Mother's Day card. And Richard, Jeff, if there's no one that decides to go first, you're welcome to call teams out. We can do it together. We can choose
This is
alphabetical order. Hi, Marnie.
Hi, thank you. So Marnie Folk, Gillette Children's Specialty Healthcare in Minnesota. And what we discussed in our group is coming up with some legislation that would create a pilot project. We looked at the existing programs in Minnesota. I know Dr. Schiff knows these well, but Gillette is a member of what's called our Integrated Health Partnership, which is a Medicaid ACO through our Department of Human Services. We are also a healthcare home for our complex care clinic through our Minnesota Department of Health. But looking at both of those programs, neither of them was really designed for our patient population, and in particular, our complex care clinic. The healthcare home is more adult focused, not necessarily pediatric focused, and the IHP is a retrospective attribution where families and patients aren't choosing where they're attributed to, and we don't necessarily have attribution for all of Gillette patients. For whatever reason, the model hasn't necessarily worked out that way. So what we've been discussing is using the data that we have through family surveys and other data points to look at how can we create a pilot project that we could bring to the legislature and look at creating something that is really designed specifically for Gillette's patients in our complex care clinic that would address the care coordination piece, the family wellness piece, and put it all together with some sort of a supplemental payment. And then just looking at how does this, interact with our patients that are in our Medicaid program, which the state certainly has some say over, and then also what is the overlap with our commercial insurance payments. So that's kind of it in summary, but just really looking at how do we just start, and create something new. And I'll let anyone else from our group join in and add to that if they want to.
And this is Rhonda, and I have to say, having both John and Kevin as part of this, I feel like they were talking to our team. Like, okay, this is what you guys need to do. It was really nice. And having worked with Jim Abler, I mean, I feel, not that it will be easy to develop the relationship. I think that's our key. We need to get that relationship built. So that's going to be our first step. Marnie is our lobbyist, our organization's lobbyist. So she already has a relationship.
And just geographically, you can spit from Gillette to the legislature if you're good,
Convenient during session.
Yeah, it's very convenient during session. So yeah, I think I think that you have, I'll just make a comment that you have some of this nuance of figuring out where it fits in the legislative package, whether you take a modification off of the integrated health partnership or off of healthcare home, and I think you probably have this, I think because we've talked at a bunch of different levels, and this is just, I know Minnesota, but I think in every state, you have to figure out when you say, this is what we want to accomplish, and you get the legislators to buy in, and then you go back to the agency and say, which way do you want to do this? So I bet you've already thought about that, Marnie.
Yeah, and that's part of the consideration. And I think ideally we'd work with the agency or agencies first to jointly propose something, or right, sometimes the agencies say we can work in partnership with you, and sometimes it's we can provide expertise. It's not on our priority list, but we can provide expertise and we're not going to oppose it. So whatever we can work out.
Yep.
So Marty, this is Rich. I'm intrigued by this. And if I said to you, what's the problem you're trying to fix? And what are the measure that you'll do, that you'll show or measures that will demonstrate success? Because I'm sort of anchoring my questions on your proposal of this being a pilot. So say a little bit about that, please.
Yeah, and I can let someone else speak to the data, but I think, for our healthcare home participation, and as someone, Ron, had noted, we've had a lot of the pediatric providers and systems, in particular Minnesota, drop out because it's not pediatric focused and the care coordination payments are so low. I think it's $40 a month. And so a lot of providers and health systems have just found that it's not even worth their time because the payments are so low. And so I think increasing that care coordination payment is part of it. And then also finding ways to increase that family participation and overall wellness part. And really, in my mind, Gillette's a participant of IHP, we're a participant of a healthcare home, but this would be a partnership between Gillette and Family Voices. And so Rhonda or anyone else, if you want to add to that.
I think the other piece is that we found to truly get, so if one of our goals is to diffuse the burden of care coordination from our family shoulders and share some of that, what we found is that takes a lot of time intensive and people intensive work. And so how do we demonstrate with data, this is the amount of time and the right people to actually start making an impact on our patients and families. I don't want to speak for all of our families, but one thing that I've kind of heard a theme throughout is there's lots of people saying that they're helping with care coordination, but I'm not feeling a weight lifted until I was a part of the Gillette Complex Care Program. And for the first time, I felt like I could take a breath. And so how do you demonstrate that with time and numbers? I'll let Rhonda and Megan, if you guys have any real data to add to that, but those are my thoughts.
Well, we have our CoIIN data, from our parents survey, but we're gonna switch to a combined PICS FECC survey, which focuses specifically on the things we think we should be making an impact on.
That sounds great. And just to be sure that, we're promoting that we're going to be measuring, and we want to measure things that the legislature feels is important. And then especially in Minnesota, you do have a lot of infrastructure, don't you, with health homes and all of that. So I think that's really great. All right. Who's the next state team that wants to do a report out?
This is Christine McCoy from New Jersey. I'm happy to report.
All right.
So our project is a little bit different perhaps from some others because the focus of the New Jersey Integrated Care for Kids project is as much about social risk as it is about medical risk. And so that and what is really distinct about it then is that the care coordination that we need to do is very much intersectoral. We have 8 defined quartile services from CMMI that are expected to participate in our project. And then we are also highly recommended to also expand out into things like law enforcement, juvenile justice, and other things as well too. So our real need is actually around number 2, the data. And so our ask at this point in time is not a legislative ask, but we have decided that our ask is really of our First Lady of the state of New Jersey. And that is because she has really positioned herself as being the spokesperson for maternal and child health. And she has an initiative called Nurture New Jersey, which had been rolled out close to 2 years, I think, before the pandemic got started, with a lot of focus in our urban areas, looking at health disparities for African American population here in New Jersey. But that's certainly not the only aspect of it. And so, getting her ear is what we were inspired to think about today. And so our sort of ask of her is actually to help to bring the administration, the different state departments to the table around the New Jersey Integrated Care for Kids project, because it launched just as the pandemic launched. And so all of our plans to sort of bring the Department of Health, the Department of Children and Families, the Department of Education, as well as the Department of Human Services that's already on board because of the Medicaid role, to the table together to talk about intersectoral collaboration and how kids do better when everyone is informed about a child and family circumstances and is able to have a shared plan of care across these different sectors. And so we really need everyone to come to the table to embrace the initiative and to say what they will gain from their perspective by being part of the initiative, and then launch into the very, very complex data sharing that is needed for the project. And one of the actual official evaluation by CMMI will be looking at the use of these very, very high-risk children of the medical system and of the special educational supports, and a number of different areas, child protective services, juvenile justice, all of those. And so in terms of the data that will eventually be available to people, that's what it's supposed to be, but we can't get there until everyone understands the value of coming to the table around this project and being not just willing, but interested in contributing their data to the project.
Christine, that's really cool. I want to ask a question about the First Lady. Does she have a program in mind, or does she have this thematic issue around maternal child health? I mean, could she latch onto your program, or does she have something else more specifically in mind, say around pregnancy outcomes or something like that?
Yeah, so most of her focus has been on pregnancy outcomes. And in fact, she just put out a request for information around creating a Center for Innovation in Maternal Health. And so I think in terms of her own very, very specific focus, that is where it's going to lie. But we just got an invitation to a talk that she's giving on early intervention. And so she is being pulled into these other aspects, sort of beyond those maternal and sort of infant birth outcomes, into the early childhood space. And so I think that's really what we're interested in, making that connection, starting with that early childhood space and then looking at the longer term outcomes, since our project goes through age 20.
One of the things I was thinking about as you were talking is a linked data system, which you really seem to need and want, could fulfill her need for in that area as well as yours, you could get a big win by funding, by going after the data integration for maternal health as well as for the INC program.
Absolutely. And I think, the state has, a fairly progressive sort of risk analysis of pregnant women who are covered by Medicaid as well as uninsured, but that again is not well integrated into the rest of the system of care that the medical care and other aspects of the care that they receive. So, right, sort of connecting those fits into her scheme. And then adding in things like early intervention, special child health services, sort of build off of that core.
Yep.
Christina, this is Rich Antonelli. In addition to the data sharing, and I don't mean to imply at all that will be easy, but boy, having that voice helping the cause is going to be huge. Where is the New Jersey team with actually formulating, okay, now that we have this data, who's going to do what? So I'm sort of thinking in the space around, will there be a locus of accountability for integration across settings, across sectors, across disciplines? And I don't want to put you on the spot. I know that you guys had a couple of years to sort of do the planning, but can you let us know, as one of the Inc. grantee states that's in the Academy, where are you at with that? Like if, poof, tomorrow everybody is data sharing. How are you going to drive? Okay, but who's on point so the family doesn't say, which of these 42 people do I call?
Yes. So the model is very, very specific about having a single point of care for each family. And in CMMI language, that person is called a service integration coordinator. And so, those teams have already been largely hired for most of the Inc. Projects around the country. And so they're very high level. We call them the air traffic controllers, essentially. They're not doing that hands-on helping you to get connected. They're not making appointments and arranging your transportation and getting you to the food bank and all of those things. They're looking at what levels of support do you already have. Well, first of all, they're evaluating our sort of automated risk system and validating that people have been put into the right risk tier based on additional information that either the family, the youth, or other trusted partners can provide about that child or youth. And then they're looking to see, okay, who can be the main person driving your bus aside from you? Who should be, so that everything gets sort of funneled through a particular care coordinator, either through an existing service that child already has, or when that either doesn't exist or is not sufficient, our alternative payment model pays for something called an advanced care management team, which is actually a community health worker based model, but with a team lead who is a licensed social worker and will be able to sort of provide that sort of backbone and coaching to those community health workers who can connect to the families in a much more granular fashion based upon culture, language, etc.
Wonderful.
And let me not forget child life specialists as well. That's the other part of those advanced care management teams.
Maybe you can find out if the First Lady of New Jersey would like to make a guest appearance for the Care Coordination Academy.
There you go.
It would be great to bring that voice in. She probably knows Carolyn Alshouse, just saying.
Yeah.
All right, next team.
I'm happy to share. It's Katie from Philly.
Yes.
Okay, so we don't have a lot of our team on today. I think we have lots of conflicts, but I think Renee Kirchy's still on, and maybe Nick and Mary, so they can chime in. But so we're doing integrated care for kids, and we lucked out that the state came out with a new Medicaid Health Choices requirement to do community-based care management program on the mental health side. And we had a chance to submit Inc. as one of our projects to fall under that new requirement. So the nice thing is we have funding for Medicaid, so we don't have to worry as much about that. So the way we thought about this was to take advantage of the opportunity for ASK, particularly because Dr. Turchi has lots of foundations that like to support the good work of St. Christopher's Hospital for Children. And so when they come to her with an ask, if we could have a infographic already created to use for that purpose. And so we actually have an MPH intern who's going to start working on this for us. And I think the data that we're going to use for now is going to be a combination of national data that shows barriers that parents with behavioral health conditions experience to maintaining custody and positive outcomes for their children, as well as local data around social determinants. I mean, Philly has really pretty horrific housing insecurity. Like, you're on a waiting list for 10 years. They actually don't even take people on the waiting list anymore because it's over 100,000 people that need affordable housing in Philly. So kind of blending some of that as part of making the case as to why an integrated care for kids model is important. And then what are the things that Medicaid can't pay for, and focusing it on that. And then eventually having, you know, we're going to create a template now so that we have outcomes and ideally data that's both quantitative outcomes as well as the family experience and care navigation, that we could blend that in and then again use it for other purposes. So that's sort of where we're at.
I love the way you framed that last part about measuring and thinking about scalability, because I think that's whenever you do something for kids, it's, you know, especially if you're at the federal level, but often at the state level, adults are usually above. And so to the extent that you and your team can find measures, process and outcome measures that could be relevant for other populations, that would be, you know, that would actually be really strategically prudent to be able to think about that.
Yeah.
Where is Dave Kelly in the process?
I'll let Renee answer that.
we can put the august Dr. Kelly a little bit on the spot, since we know that he's a, you know, he's cut from the same cloth as Dr. Schiff.
Yeah, he sure is. And he's, you know, I think as things evolve, I mean, fully engaged. And I think once we sort of have, you know, our finalized measures, he's very interested. One of the things we've talked a little bit about is crosswalking our outcome measures on behavioral health with the quality measures for physical health on the pop health side. So that's something that, you know, because we know that integrating behavioral health in primary care, I mean, our hypothesis is that those things will favorably impact or associated with many of the measures that physical health Medicaid plans are looking at. So really kind of looking at a sub cohort. And so, you know, having discussions with him once we finalize this is key. The other interesting thing, we were actually talking about this a little bit today, that he's in full support of this as well, of us moving ahead. Secretary Miller, who had been in Pennsylvania, recently left, went to Kansas, I think. But one of the things she was really pushing in her role was like a data platform, like an Aunt Bertha, or one of the, you know, there's Healthify, there's various out there that allow you to kind of look at closing the loop with CBO referrals and things like that. And so that was something that the state was really coming out, Pennsylvania at least, is sort of recommending a single platform. Very much came out of a lot of the work that Dave Kelly and the work group we had in Medicaid, kind of looking at how do we not just screen for social determinants and make the referral and ensure those are closed. So I think potentially, I'm not sure exactly the impetus for kind of backing down on endorsing Aunt Bertha, but the state has sort of backed away. Perhaps it's just, you know, Secretary Miller leaving and lack of advocacy. But again, I think Dr. Kelly is very much in those kinds of platforms. Really help us look at outcomes, and also would really allow this to be externally, you know, generalizable and valid, you know, within Pennsylvania and beyond. So that's another conversation we want to have with him. You know, just because Pennsylvania has backed away from sort of mandating it, if you will, doesn't mean that this project shouldn't still move forward. There's a lot of major health systems that are going to use it. And we think it would be a really good way to measure some of the process measures, as you were pointing out, Rich. So I think a conversation with him as we codify this all together is in order.
Can I
That's
ask,
really, really good. Go ahead, Jeff.
Katie, can I ask you a quick question about this community-based care management Medicaid service?
Sure.
Because I think that's sort of been a lot of the Inc. goal is to get that stuff paid for. Is that, you know, do you guys feel like that's adequate funding at this point? And is it funding on like you submit a bill for the service, or is it some sort of a per member per month kind of thing?
So they've been doing it actually on the Dave Kelly side. So on the OMAP, the Office of Medical Assistance Programs, on the physical health side, they've had this requirement, and 2 of the MCOs have actually contracted with CBH. So we could, so for the folks, I've mentioned this before, but I don't expect people to remember, we're a carve out state, right? So, so the physical health managed care companies, 2 of them contracted with us to push in behavioral health services into primary care settings and the emergency department. And we've been doing that since 2015. And then OMSAS, I don't know whether it was at that level or at the secretary level, decided to do the same thing on our side. And actually, I mean, I'm kind of holding my breath, to be completely honest. It sounds like very recently, Renee, I didn't even get to share this with you because I feel like it's not an issue until they tell us it's an issue. On the physical health side, there's some issue, I think, around paying for some of the staff positions from the managed care company that are physically pushing in. We have not heard that on our side, so we are just moving forward. And I'm impressed that they've been able to, because to me, some of what they're doing seems like you would have to have a Medicaid waiver. So, we're required to contract with community-based organizations. So we're using our budget, and it's funky. It's a per member per month budget, but it's not, and I'm certainly not a Medicaid expert. I've been at CBH for 5 years, but it's per member per month, but it's coming under the admin line. So it looks like medical claims, but it's not. I don't know if that's how often that's done. So anyway, so the budget, actually, we have a decent budget. Like, we can do a lot. We're hiring, CBH is hiring a coordinator, a supervisor, 3 clinical care managers who will all be co-located at St. Christopher's Hospital. And then St. Christopher's is going to use the budget that we're paying to hire care navigators, a clinical psychologist, a care navigator supervisor, and contract with the community-based orgs that would address the social determinants of health, as well as pay for other supports like, the team's going to need iPads to do the screenings. And we're even looking, to Renee's point about Aunt Bertha, just supporting the startup cost of getting St. Chris on Aunt Bertha because it's directly relevant to the project. So, we're doing it at 2 of the 3 clinics at St. Chris. I mean, we're never going to be able, they serve so many kids at St. Chris, and we don't know what the volume is we're really going to be able to touch. And so, of course, we hope that we'll be able to expand it. But I think they gave us a good amount of money to actually do meaningful work in terms of creating teams that could work together. And so hopefully CMS is just like, this is great.
Well, I think you can do it because it's on the admin line of the MCOs, right? And they're paying, so there's some flexibility there. But I think that that's a model of how to ask in a state that's already moved along and bought in the concept of getting care coordination at the provider level and integrated care coordination with behavioral health.
Yeah, the only no that we got on our budget ask, and I wonder if it would be different if we did it as line items, was, they want us to address social determinants. And so we are working with CBOs that St. Chris has relationships with that do really good work in this area. But transportation, childcare, and what the heck was the other one? Transportation, childcare, and communications, right? If you're going to do care navigation, but you can't actually reach the person because they don't have a phone, that's a problem. So we, instead of doing individual line items, we tried to do a discretionary fund, and I thought it would get shot down, and it did. So they said that's where we would need the waiver. And I was like, we're doing a lot of other stuff and we don't need a waiver. But so that's the one thing that we still want. And I do think some of like the ride sharing, I think we can get away with that because it's already, St. Chris already has a contract. And so if we pay St. Chris to contract, then they're addressing that through a CBO. So, it's a little funky, but.
Lots of detail, but I think the principle is really kind of cool about per member per month down to the provider level, you know, supported by the Medicaid program through the MCOs, you know, so.
Yeah, I feel like what we want to do, like we're all like, oh my God, I can't believe we're getting to do this. So
Yeah, exactly. Congratulations.
Yes, indeed. So I'm going to make an observation now, and this is not specific to the teams that have presented, because my hypothesis is that it will apply to the teams that are about to present. But if you look at measures, outcome measures that are available right now in the broad universe, not just in the Medicaid child and adult core sets, but the broad universe, there are really very few measures for children with medical complexity that one could put into a contract across a state Medicaid program. Now, that is not only not a problem, it's an opportunity. So to the extent that as many of the teams in this Care Coordination Academy can come to some sort of general consensus, and I'm not saying we need consensus, but we should, I'd like to maybe say in a future session, each of the state teams should be invited to share what are the measures that you're proposing. Because I think the work with CMMI, in particular the INC grants, there weren't a whole lot of new measures put into that space. And in fact, I'm aware that one of the measures might have even gotten pulled already. So this presents opportunity for folks that are working on Mother's Day cards. So if each of the teams could be thinking about, as we develop our Mother's Day card and as we develop what the outcome and process measures would be, I can tell you CMS is looking for that kind of input now, and having it bubble up from the communities through the state programs up to the federal government, in my opinion, for the next 2 to 4 years will be an almost unprecedented opportunity to advance integrated care outcomes for patients with complex needs. So that's really, really great to hear the progress that you guys are making. Thank you. Who wants to follow our Philadelphia, Pennsylvania?
This is Lonnie. This is Lonnie from Michigan, and I'd be pleased to go next.
Yes, Lonnie, please. You always contribute something that I learned from, so please jump in.
Sure. Well, let me start by saying I didn't want to report out first today because we didn't actually follow the discussion guide or the questions that were asked. But for good reason. We really, the Michigan team felt that we're entering this conversation, acknowledging that every state is at a different point from each other, but we really feel that we're in some ways even more unique or distinct from the others in that our team and the team on the call today, with the exception of Steve Fitton, the rest of our team are all State Department of Health and Human Services staff located within the Medicaid administration. And so we're not engaged with determining what we're going to ask state government or what we're going to ask Medicaid. In fact, in some ways, we're the recipient of the ask. We've received a proposal already in Michigan from a set of partners, the Michigan Health Endowment Fund, Michigan Medicine, and others. And so we're in the midst of responding to that ask. And so again, in some ways, you know, things are really flipped around for us. With regard to legislative engagement, although we in the executive branch, you know, are not in a position to request, you know, we don't, well, from our level as a staff team within the executive branch, we don't engage directly with the legislature. But a couple of years ago, actually, I had some conversations with Dr. Ken Pittidge, who some of you know from Michigan Medicine, and he's the lead for the pilot initiative that's taken place in Michigan, the Partners for Children program. But I had helped connect him with both the Michigan Council for Maternal and Child Health, along with some of his colleagues at Michigan Medicine, their legislative liaisons there, and they were successful in getting language added into the annual budget appropriation that gives us the authority that we think we need to move ahead with this Children with Medical Complexity initiative. So we already have, you know, legislative support, and so for us, we're working, you know, within the structures of state government. Our ask is to, you know, to obtain the approval to move forward in establishing a health home for children with medical complexity statewide. We want to utilize the authorities through the ACA, Section 2703 of the ACA, and really positioning ourselves for when the ACE Kids Act finally moves into full implementation, to have us, be well positioned to move, full speed ahead with that. With regard to data, we have data already with regard to an evaluation of the Partners for Children program that came from University of Michigan's CHEER unit, showing cost savings for the children who participated in the pilot. And even more important than the cost savings perhaps is the outcomes that the families experienced. Less ER visits, less inpatient stays. What we believe are measures that reflect on improved quality of life for the families with the children who are enrolled in the program with medical complexity. With regard to other aspects of the data conversation, we've had lots of discussion and continue to discuss how we can query the existing data systems to identify which children in Michigan, in fact, would qualify under the definitions of children with medical complexity. So as we move ahead with planning for implementation of the health home, we need to be able to identify who would be in and who wouldn't qualify. And there's members of the team from Michigan could expand upon that if there's interest, because they've been much more engaged in that data conversation than I. From where I sit, I just know it's been more challenging than one would think to identify, to query the data systems we have within Medicaid to identify the children that would and would not qualify for this. So that's where I'll pause. I'll allow others from the Michigan team, anyone on the team is welcome to jump in and add to that. And of course, we'll be pleased to respond to questions. Thank you.
So if there's no other Michigan folks that want to jump in, I have a question, Lonnie. You mentioned cost savings, and that's really, really important. But I'm wondering if you could unpack that a little bit. Is the expectation that as this care model moves forward, that cost savings is an expectation, or what I'm seeing in some states is we're tracking costs. There are some kids that clearly will spend less, but there are other kids, I'm thinking persons with developmental disabilities, autism, if you will, underserved, where in fact their per member per month cost may actually go up. So how critical to the model that you just outlined is explicit demonstration of cost savings?
That's a really good question. And I'll again welcome colleagues from Michigan to jump in after I give an initial attempt to respond to the question. With the proposal that's been sent forward to leadership within state government, that proposal has included the documentation that cost savings are anticipated. I think it's a fair question as to whether, if those savings materialize or don't materialize in the future, the impact that would have on moving, and continuing to move ahead, I think is an open question for us to have, because there have been some questions raised within the conversations within Medicaid that, that there's a cost savings demonstrated thus far through an analysis of claims data, but that analysis of claims data doesn't include the actual cost of the program itself, which was funded separately outside of claims. The savings that have been demonstrated are of a significance that they certainly cover the cost of the program and then some. And so we continue to anticipate that there'll be a cost savings associated with the program. But we don't want for the proposal to be totally based on this is a cost saving measure and this is why we should do this, because we understand there's real value and real benefit to the families who are experiencing the healthcare system, and that this program will be beneficial to them as well. And so we don't want to place all of our eggs in the cost savings basket, because if things evolve in a way that doesn't materialize the way in which we're anticipating, we don't think that should then be reflective of a failed program. So
yeah,
let me
exactly.
let others jump in
Exactly.
as well.
Well, let me comment and then because I think that's exactly right. We can track, you should be willing to demonstrate which direction cost goes in, but if you're only being held accountable for looking at claims, the family that doesn't lose their job because they're coordinating care 25 hours a week, the child that is able to graduate junior high school because they're well enough, those aren't going to show up in claims. And so to the extent that you could make sure that to use some outcome jargon here, the primary outcome shouldn't be cost savings. But certainly in the era of value-based care, we need to be able to pay some degree of attention to cost and utilization. Steve Fitton, I saw you unmute, so I assume that you are standing in the on-deck circle?
That is a good interpretation. You can see me swinging my bat here.
I can. Get into the batter's box, my friend.
So just to add on to what Lonnie said, and great job, Lonnie. The financial part of the proposal also takes into account, and to some extent is selling, based on the fact that there are significant federal subsidies for these health home services through 2703 waivers and the ACE Kids Act. And so part of what we were trying to alleviate is the anxiety that they would have to put in a budget request, because Michigan has not really, even though it prides itself, and I know I prided myself when I was in on the action, prides itself on optimizing federal revenue. The situation as it relates to this proposal, there really are opportunities to optimize federal revenue that haven't been there. And that includes these CMDS clinics that are for complex care children, but where there should be an established service in place. And they've been paid for with straight general funds. So there's an opportunity just to get Medicaid match. And Lonnie and his staff have been working on that before I got involved. But anyway, so we tried to put together a series of factors that would be beneficial to the state in terms of federal financing, cost savings, and essentially trying to alleviate the need for a budget request to get this rolling. I think the factors that you brought into play, Rich, are a part of a deeper discussion that I think we'll have down the line, because the long-term consequences of these interventions in terms of impacting other human services domains and in terms of keeping families intact and enhancing their ability to work and earn income, all of those come into play and really haven't been part of these more narrow claims-based evaluations. So I think it's what do they say? It's kind of a process, and we actually have thrown into the mix in Michigan adopting the Family Opportunity Act as another policy component, and it has the benefit of converting what are now general fund expenditures to Medicaid expenditures and getting the matching rate for a number of children there, and we don't know exactly how many. And then just a final note, and this really has to do with the idiosyncrasies of states, and that's why everybody's in a slightly different boat. But in Michigan, the developmental disabilities and autism that you mentioned are being handled by the mental health system and their pediatric component, and Children's Special Healthcare Services as an organization that Lonnie leads is specific really to physical health issues for the most part. And I can't remember, Lonnie, if autism has come into your domain or not, but in any case, there are all these factors that that have really worked to make Michigan, there's a great opportunity, and the financial opportunity, is very positive, and that's part of the sell.
That's wonderful. Heather, how are we doing for time in terms of number of states? I think we've got probably about 12 minutes left. Are we doing okay pace-wise?
A little bit okay. We might want to go a little bit quicker so we can try to hear from everybody.
Okay.
But we're doing okay. It's lots of really good conversation, so it's hard to put a time limit on any of these.
All right. Well, but again, but it's actually really exciting to see how much substance is evolving amongst each of the teams. Okay, next state.
Mary just offered from Indiana to go. Mary Ciccarelli.
Mary.
Hi, everybody. We actually didn't exactly follow the script either. We've been working on our Mother's Day plan, and we kind of we have a 2-pager now in writing. And so our And so we just were refining some of that at some of the suggestions we heard today. Where a demonstration project funded by Medicaid that's collaborating in the 10-state CoIIN collaborative, and we're meeting with members of our Family and Social Service Administration and Medicaid operations rather than legislators. And they've been invested in the program since its start now 2 years ago. Our data we've collected has been both the care coordination measurement tool data episodically, as well as the 10-state CoIIN family satisfaction survey. We plan to continue that even as the CoIIN is ending, using that data because we have a comparator over the period, that we've already measured it. And we can show a significant rise in our care coordination composite and our medical home composite over the 2 years in our population. And our composite increases are notably higher than the 10-state averages in the 10-state collaborative. So we think our model has met the brief in terms of what we were asked to do in that project. And our model is an embedded nurse care coordinator in primary care where 100 kids get identified who are complex. And they are supported and trained by a central core in a resource center that helps do that. And our key messages are that family and primary care practices are both really satisfied with the model. We have some lovely quotes from primary care providers who used to literally groan when they saw a child on their schedule to now feel both prepared and able to manage the child with the use of a well-constructed shared plan of care. And they can actually address parents' needs rather than try to just make sure they've documented what they needed to document for a kid's well child visit. And our ask is to further build out the model into a 12 to 15 advanced medical homes scattered in a geographic manner around the state to collect these highest risk kids, organize their care into shared plans of care, and create a point of contact for all of them that greatly exceeds the experience of our managed care organizations in attempting to coordinate for these patients. We've been able to show a 97% acceptance rate and retention rate, and our MCEs, can't get the families to answer the phone. We only have about a 20 to 30% family reaching out to us regularly to ask the questions rather than the care coordinators having to do that reach, but that's still way ahead of what our MCOs have experienced. So I think that's our model. I could keep talking, but I said I'd go short.
Well, I'm just so proud because you're backing up your vision, your instinct with data, and that is exactly right. So kudos to you and your team. Who's after Indiana?
I have a couple teams left, either Alabama, if you're out there.
Alabama, California. We're not letting California off the hook here. And I think SBA, Judy, I don't know whether the three teams want to speak collectively or individually as time goes by, but why don't we do Alabama, California, and then Judy, you figure out how you want to divvy up the voice of your three teams, okay? California? There we go, safety, great. Yeah, no, start with Alabama, please.
Hey, everybody. So for those that said they were a little different, I guess we're a lot different than a lot of the teams in that we are piloting a tiered care coordination program within our existing care coordination program through Children's Rehab Services that administers the Children with Special Health Care Needs portion of the block grant in Alabama. And so our data is going to be our pilot data. So we're currently starting August 2nd, we will start our pilot for our tiered care coordination assessment tool. And then we will move into a longer phase pilot to see how the tiered care coordination impacts our current care coordination. Is it identifying the individuals that we feel like need more care and more focused care? Is it do the care coordinators feel like it is beneficial for use, and is it really focusing on what we want it to focus on? And our evaluation components for our pilot are being conducted by the UAB School of Public Health, and we have a contract with them, so they are helping us through our pilot phases. And then I also want to say that even though we're not using the PICS or the FECC, we did use both of those tools in creating our comprehensive care coordination survey that we're going to be conducting with our families. It's part of our block grant activities. And so we're really looking forward to that, having that data. And then if we just make the decision to implement the tiered care coordination component in our, across all our entities, then we'll have that block grant data and we can compare it and say, well, here we weren't doing tiered care coordination assessment. And then 3 years later, here's where we are and here's what the data is saying as far as our comprehensive care coordination services. So we don't have an ask for our legislators. We don't have we're really asking ourselves, is this working for us? And do we want to take it statewide? So again, we're a lot different, but we're doing some really good work and we're real excited to see how the pilot goes.
The timing for the pilot?
We're piloting our tool for 3 months. We'll start August 2nd. So we'll do August, September, and October, and then we'll move into a year-long pilot. That's our goal right now, is to do a year-long as far as the tiered care coordination itself, and
Nice.
comparing it to our current model, and then looking at the tiered care coordination assessment.
Wonderful, wonderful.
Great.
Thank you.
California.
Hi, guys. So Annie Carpinelli from Chalk in California. During the office hours for technical assistance, we talked too much, so I was trying to be considerate and let other people go. So we're in the midst of analyzing the data from the CCMT, the Care Coordination Measurement Tool that we have housed in REDCap. And essentially we're focusing on sustainability and growth for our already quite robust care coordination program that we have. So we're really focusing mainly on, talking to the powers that be within our own institution, the C-suite and things like that. But one of the things that we discussed, one of our astute social workers pointed out during our breakout, that we really do need to focus more on creating basically standardizing our approach and the way that we allocate resources based more on real-time needs rather than what we're told is, risk stratification from Medi-Cal. So we're fortunate that we do have care coordination financing built into Medi-Cal. And it's wonderful that we have that, but it only goes so far, of course. So it depends mainly on diagnosis of patients. And we're kind of unique in that Chalk Health Alliance, which is a hospital physician consortium that's basically like a safety net for our Medi-Cal patients. We have about 150,000 patients as our members, which I still have a hard time saying member, but patients, members, but only about 10,000 of them are included in the payment that we get for our patient care coordinators. And then we have on the hospital side, lots of nurses and social workers and care management assistants who don't get that direct funding, but are also providing a substantial amount of care coordination. So we're looking into ways to, again, sustain and grow our program. One of the things that we've done is we're in the middle of a 2-year pilot with United Healthcare. So we're looking at our commercial payers and seeing how they could chip in and how we can, serve the care coordination needs for those kids. So even though they might have more resources, obviously they have needs too. And we've had a lot of success in our family meetings, even incorporating a family advisor from United and answering on the spot questions about benefits with families, because a lot of times those are their main questions. And so it's wonderful working with them. And then we also just talked about some quotes that we've heard from families. We have Angie Guzman, who's part of our Family Advisory Council. And we were just talking about a meeting that we had a couple weeks ago, one of our virtual family meetings that we had, which is part of our care coordination program. At the end of the meeting, which included several people, including a nurse from the hospital, a social worker from Czech Health Alliance, someone from Regional Center, which is basically like early intervention in California. And the mother, at the end of the meeting, the mother said with an interpreter, I think the meeting was in Spanish, she said, "I just want to thank you all. I feel heard and I feel seen." And we just thought that was really impactful. I hadn't heard anybody say it so succinctly.
Wow.
It really meant a lot to hear that. And so we want to pass that on to the powers that be who will decide how the future looks for us.
That's excellent. Just quickly, the United Connection, the broader population, what percentage of the population will you cover if you start to think about these adding on other payers? So it's interesting that you've got enough maturity in your model to be thinking about that expansion. So what percentage of the kids under your care would be covered under this model?
So, well, United is only a fraction, of course, of all the commercial kids. Sarah, are you on? Dr. Marchese, are you on? I might hand that to her if she's available. But it would be a very large portion, but we have several commercial carriers. So we're hoping that the pilot will show, demonstrate to others the value and that they'll want to jump on the bandwagon with us. But I don't know the exact numbers, I apologize.
Yeah, even in our Medi-Cal population, we have funding for about 7% of our members, and our pilot on the United side is probably a smaller percentage than that. So kind of all still in the works, but I think we'd at least like to see, somewhere around 7 to 10% of the population be eligible.
Okay, thank you. Thank you. Great stuff. Judy, do you have a quick summary for all the SBAs that you'd like to throw in, please?
I do. The SBA is working, the Spina Bifida Association, with 3 clinics, Spina Bifida specific clinics in Pennsylvania, Ohio, and Kansas. And I'm pleased to say what I felt today in the collaboration is giving strength to the clinic coordinators, which are strapped because there's not enough clinic coordination to realize the benefit the patients need. So measurement has begun. I know that the Ohio folks met with you, Rich, about the PICS, and one's going to go with the CCMT. And we talk about, we're going to have to quantify the care coordination activities that are performed by many people to get folks working at the top of their license. And I learned that so well from you, Rich. So anyway, I feel optimistic, and I'm grateful that we have a little longer to do this, because we're beginning, I think, to get some attention they are from their leadership. And if we can, the leaders above the leaders, and if we can learn from that and take it more broadly in the association with other clinics, it will be very valuable to us.
Yeah, and I don't want to embarrass Spina Bifida, but I will tell you, I use the example of the Spina Bifida Association when I speak to statewide programs, because this sort of siloed approach, every disease category has its own clinic. It's impossible for Medicaid agencies to think about that. So, Judy, the work that you're doing to try to get a unified voice, a relatively uniform way of capturing the value of equitable care is critical. And I will continue to sing the praises of Spina Bifida, and there are several other organizations that would like to do this. So we're going to close now. We're literally at the top of the hour. A huge note of gratitude to Heather, to Erica, to my BU colleagues, Jessica, Meg, Beth Lynn, to Jeff Schiff, and to Renee Turchi, and to Steve Fitton, the core of the faculty leadership for the Care Coordination Academy. I put several times in the announcements, and you'll be seeing an email as well. We are really pleased to announce an extension of the Care Coordination Academy through May of 2022. There will be no gaps. We will continue the momentum. This was session 2 of 3, so there will be a trilogy attached to the Mother's Day card with work behind that. So there will be a constant and consistent and persistent theme. Implement, measure, capture the value, sustain. So more to come. Thank you to everybody. Meg wasn't here with us today, but she sends her deepest gratitude as well. And I just want to end with one word. Wow. Look at the progress that you folks are making in the blocking and tackling space. Wow, wow, wow. Families are depending on us to get this right. So thank you, everybody.
Thank you.
Thank you, everybody. The evaluation has been shared in the chat, and I will send along in just a little bit an email that will include the attendance link and the evaluation link for those that might have missed it. Thank you, everyone. I'll send out also more info too about future sessions, so you'll be seeing meeting invites shortly. Have a good rest of the day.
Bye-bye.
Thank you.
Bye.
Okay, so I actually have to jump off too, but it's so nice to see you guys. We'll connect soon. I know we have some meetings coming up. Seems like it's been a whole month without connecting, but we'll be in touch. It was nice to see you. It looks like you're back in the office. Are you guys in the same room?
we're in the same office area, but
I love it. We're getting back to real life. Okay.
Yeah, slowly but surely.
Yeah, right. Have a good day, guys.
Bye.
Bye.